Welcome to Crime Corner Investigates. Um, I cover high profile cases, trials, true crime. I usually do deep dives into timelines before and at the onset of a high profile case. And I usually cover trials pretty deeply. The Lindsay Clancy case, I did not want to cover because it triggers me. But I am going to go into detail about some things with the case and getting mental health treatment and the barriers that exist. Um, I was a youth mental health first aid instructor several years ago, and I worked for the county mental health center doing education and outreach. So mental health first aid is a course. A nurse developed it in Australia, probably about 15, 20 years ago. Um, and it's an 8-hour course. It used to be only face to face. Now you can do it online, you can do it virtually, you can do it in 2 sets. In the summary, I'll have a link where you can go on the website and find a course near you. You usually get a manual to keep. At least we did when we did face to face. Everybody got a manual. Um, the manual itself was $30 at the time, so that might be outdated. Now, mental health statistics per se that are included in that course can be outdated because they publish all the books way in advance, and that can quickly change. But mental health first aid is how to treat a loved one that's in crisis, or where to go, or how to get help. So we're going to touch a little bit on that and entwine it in the Lindsay Clancy case. So I do know a little bit about it, and I know enough to know what we should be talking about instead of sensationalizing this case that is just traumatizing for me. I am covering the Nancy Guthrie case, the Tyler Robinson case, and Luigi Mangione. And I do have a playlist for all three. I am a bit off the beaten path for covering cases, so most of my videos are not the same as other podcasters. But I do offer thought-provoking ideas, and I do deep dives into cases in a different, unusual way. So if you like my videos, hit like and subscribe and the notification bell so you can see more of my videos. Now, before we talk about the Lindsay Clancy case, viewer discretion warning. If a sensitive topic such as the Lindsay Clancy case may trigger you, step away from the video. Or if you have small children in the room, put some headphones on so they don't hear this. But there is important things in this video on how to get treatment and how to help a loved one that's in a crisis. This video is a short video, so it's a snippet of what you need to know for you to keep your family safe in a crisis. I highly recommend taking the mental health first aid course. And like I said, the link will be in the summary. I did teach youth mental health first aid to youth pastors, anybody that worked with children, teachers, counselors. It was an 8-hour course. I was a certified instructor several years ago. My certification has lapsed, but there's still important, relevant information to this case. And I also have a similar case in my family to the Lindsay Clancy case years ago. So I do have some experience. So let's just start with her charges. She's pleaded not guilty to the murder charges. Her defense attorney doesn't dispute that she caused her children's deaths, but argues that she lacks the criminal responsibility due to severe postpartum psychosis, bipolar disorder, or overmedication. The prosecution contends they were calculated and premeditated, highlighting that she deliberately sent her husband out of the house to pick up dinner and medication to create a window of opportunity. The current status of the case is that closing arguments are expected to begin early next week. So I hope you watch this video as we go into the barriers of getting treatment in a crisis and what may have happened to her. The difference between if she's found not guilty, she'll be in a psychiatric ward, hospital, instead of a prison. That's the difference. I mean, she's going to be in a psychiatric ward if she's found not guilty. But if she's found guilty of first-degree murder, she faces a mandatory sentence, life in prison without the possibility of parole. If the jury finds her not guilty by reason of lack of criminal responsibility, insanity, she'll be legally committed to a state psychiatric hospital. We talked about mental health first aid. It's an evidence-based training course that teaches regular people how to identify, understand, and respond to signs of mental health crisis and substance abuse disorders. We're going to talk about signs and symptoms later on in the video. A lot of people suffer from a mental illness or have for years and do not know how to identify the signs and symptoms to even begin to get treatment. That was not the case with her. She had been trying to get treatment. She had been to ask for crisis help a few times. So she knew where to go. Mental health first aid is similar to traditional CPR. It teaches you how to assist someone having a physical mental emergency until professionals arrive. Mental health first aid does the same thing. So you're going to assist that person until you can get them treatment. And they have a 5-step action plan, so it'll help you remember the course. Let's talk about, and there's a lot of statistics in that course. We're going to touch on some of them too, so that you know what the statistics are in the U.S. The rate of suicide in the U.S. is, in 1995, it was 11.5. In 2005, it was 10.9. In 2015, it was 13.3. And in 2024, it was 13.7. The county that I lived in when I taught youth mental health first aid, it was 19%. So it was much higher. So the state that you live in or the county that you live in could be higher because of certain things. And we're going to go into that. Now, we do not have statistics on those who have thoughts of suicide who murder. We should, but it's thought to be very, very low. Most people who experience suicidal thoughts never harm anyone else, so that rate is thought to be very low, in the 1% range. Now, tonight or tomorrow in the summary, I'll have resources and links to everything that we talk about, so that you can look it up, the statistics, everything. Now, a forensic sample of filicidal women who have, let's just say filicidal women, 2.7 had psychotic symptoms at the time of their offense. In that study, women with psychotic symptoms were more likely to have attempted suicide at the time of filicide and to have communicated concerns or homicidal thoughts about their children before it. It does not provide a comparable percentage for prior suicidal thoughts. So let's look at the states, the highest number of suicide rates. Which is in no mean, even if you're in a state that's a low, because we're going to talk about that. Alaska rates at the highest at 29.7, their percentage of rate of suicide. Their estimated adults living in a household with firearms is 59%, which is on the high scale. Wyoming, Montana, New Mexico, South Dakota are in the top 5, along with Alaska. And they also have high rates of firearms. Now, you're going to find this interesting, but I'll tell you why. Massachusetts, where Lindsay lived, the rate of suicide was 8.3, and their rate of firearms in households was only 9%. It is not due to a low percentage of firearms. It's due to having access, easy access to complete a suicide. Now, we usually say complete suicide instead of commit suicide because of the derogatory term. So complete suicide is better to say. I oftentimes forget and say commit suicide, but when I worked at the county mental health center, we were taught to say completed suicide when we were teaching our classes and stuff. The United States has a 13.7 as a whole rate of suicide, and about 40% households have firearms. Firearms accounted for 56.5 U.S. suicide deaths, hanging 23.3, and poisoning 11.6. Firearm access does not necessarily cause suicidal thoughts. So let's be clear on that. Rather, when someone is already in a suicidal crisis, immediate access to a gun makes an attempt much more likely to be fatal, because guns are highly lethal compared with other methods. So we're going to talk about what to do when a family member is in crisis and you do have firearms in the house. Now, on December 31st, 2022, Lindsay went to Massachusetts General Hospital, the emergency room, because she was in crisis. She needed help. She went with her husband. She was having persistent thoughts of suicide. Early the next morning, the staff referred her for inpatient psychiatric care at McLean Hospital, where she spent several days, and then she was discharged. Now, reporting on the ongoing trial says she voluntarily checked in on January 1st, stayed for nearly 5 days, and was discharged on the 5th with outpatient follow-up and prescriptions for anti-anxiety medication and sleep aid. Dr. Goodhart, the McLean psychiatrist who treated Lindsay during her early voluntary admission, testified that the hospital assessed Clancy at low or minimal safety risk at discharge. She said she had no concerns that Clancy was a danger to herself or anyone else. That's in dispute in the trial. Clancy had reported depression, anxiety, feeling numb, and prior suicidal thoughts, but did not describe a suicide plan, risky impulse behavior, or current intent to die. Now, you can have feelings of suicide, but you don't have a plan. So that's what she said. That's what we're told she said, that she didn't have a plan. So the doctor thought she wasn't at high risk for suicide, and she didn't want to die. Sometimes people are suicidal. They're so depressed, they just can't bear to live that way. If you can equate it to somebody that is in extreme amount of pain because they're being tortured, it's a mental health torture and they want it to end. So some people have feelings of suicide because they just don't want to go on anymore, because they just can't bear it. Now, before I forget, because it's on my mind, it's a big thing, because somebody had brought this up to me, that their loved ones was having, depressed, and they were a teenager or a young adult, which are at high risk. Young adults can be at high risk for suicide. So I talked to her about what to do. We're going to talk about that in the video. Trust me, we're going to go into detail on how to help somebody. But she thought, because of her faith, that there would be no way that her loved one would do that. And that is false. So do not, if you're trying to assess whether your loved one, what level of care or crisis they're in, that has no bearing on it. They still can complete a suicide, even if they're severely religious and believe they're going to go to hell. If they're in so much pain, they don't want to live, that is not on their mind. They don't care. So before I forget, I just want that to be known so I don't miss it. The doctor said that Clancy identified her children and mother as reasons she would not harm herself. So she was telling the doctor this, that, oh, I would never do that. So she was classified at a lower risk. But her defense attorney questioned Goodhart about whether her evaluation had adequately captured Clancy's suicidal postpartum symptoms. Goodhart acknowledged that the intake record reflected suicidal thoughts starting after medication changes. She testified that Clancy reported suicidal thoughts, but no intent or plan, and that she knew Clancy was struggling with suicidal ideation. The defense also raised that Goodhart did not know Clancy had called suicide hotlines twice and that inpatient team had not made additional collateral contacts, such as speaking directly with family members for the risk of assessment. And we're going to go into that detail later too. The details of her assessment, medications, and discharge are part of the disputed evidence in her criminal trial. Now, just for context, her mother and husband testified that Lindsay told them that she had thoughts of harming her child. But apparently, she didn't tell them that at intake, and she didn't tell them that at the psychiatric hospital. That would have placed her at a higher risk. Why she didn't, either stigma or afraid that they would take her children away. Her thinking was distorted. And a forensic psychologist on the stand, I want to say yesterday, said that's part of her distortion. She wasn't thinking straight. If she was thinking straight, she would have told them that. It's real important when you go to do an intake, when you're in crisis, to write a list down of exactly what is going on. Don't minimize it. Do not minimize your symptoms, and don't lie about your symptoms. Be very clear with what's going on. You're suicidal. You have a plan. You've attempted suicide. You're having feelings of hurting your children. You're having feelings of hurting someone else. These make your risk of completing a suicide higher than somebody just thinking about it. So what you say matters when you go in for an evaluation. So we're going to go into detail on what and how to advocate for yourself. You can have a person go with you when you're in crisis to be evaluated, a trusted person, a loved one, to help advocate for you. According to testimony, she did not tell them during her assessment she was having thoughts of killing her children or a plan, or she was admitted to short-term psychiatric care. Now, here in the U.S., we have short-term and long-term psychiatric care. And short-term, so from the hospital, when she went to the hospital, to the ER for a psychiatric assessment, They assessed her at low risk, needing a short-term bed. So they're looking for a facility that has a short-term bed. So right out of the gate, she was classified as low risk, needing a short-term bed. When she was going to get evaluated, they were going to help her figure out a plan, blah, blah, blah. Well, I'll tell you what I think about that. Anyway, her husband did go with her, but we do not know if he told them all the symptoms. And I do think he is suing everybody about everything. So I don't know if they just didn't put it in the records. I didn't watch the whole trial. My video is about how to get help and what might have failed in her case. So I don't know if he testified, or I just started watching it. I didn't want to watch it because it might trigger me. And that is important for self-care if you've had previous trauma or not. If a case triggers you, then step away from it, especially if you like true crime like I do. You know, there's some cases I just don't want to follow, and I didn't want to follow this one. My daughter-in-law asked me if I was going to follow it, and I'm like, no, I'm not touching that case. I don't even want to hear about it. But I decided to twist in, try to get mental health treatment and get the word out because it's very important. So ask a trusted person to come with you to ER, participate in the safety plan, because they give you a safety plan when you get released. And that person, if they live with you, can help you. If you live alone, that makes you at higher risk, and you might get a longer term stay because you don't have anyone to monitor you. So those are part of your plans. She did have her husband with her, so I don't know how much of her safety plan he was involved in. But they can tell the person during assessment what they have observed, because sometimes that somebody that's having in psychosis or somebody that's in crisis, they don't know the proper words to say how they're feeling, but their loved one can explain, or they might miss something. So it's real important to get a notebook and start writing down your signs and symptoms every day and put the date. You can put your numbers to your therapist, your psychiatrist, your medications. Get a notebook. That's number one. If you're having, or you're depressed, or you're having a mental health crisis, get a notebook and start writing everything down and use that notebook. Keep a diary, because when they prescribe you antidepressants or antipsychotics, you want to keep track. You want to do a mood tracker from a level from 1 to 10. A level 8 is I'm feeling extremely depressed, hopeless, no energy. Or today it's at a 7 or a 6. So you're improving, because it takes 30 days for medicine to start taking effect. You don't take antidepressants or psychotic medicine and it starts working right away. It gradually progresses. I don't know, my hair always gets messed up. So keeping a diary of how you're feeling can help when you go back to your psychiatrist appointments who's prescribing you medication, or your therapist. So he could have said he hasn't been sleeping. He obviously should have said, she told me that she wanted to hurt the children. But he might not have wanted to, because she didn't want, because he was afraid they were going to take the children. I don't know. Escalating behavior, isolation, access to means. If you have firearms, he'd want to bring that up. Yes, we have firearms in the house, because that'll be part of the safety plan, to have them removed or locked up to keep that person safe. or she doesn't feel safe to be alone, it can be helpful to the clinical team. So what does ER do when you go to ER? When you go to the emergency room for an assessment for a mental health crisis, they check for urgent medical causes and medication substance issues. They keep the person safe while a clinician performs a psychiatric assessment. They provide emergency treatment and observation. They decide whether the person needs discharge or with urgent follow-up, a crisis stabilization program, which I think that's what they put her in, a crisis stabilization program, a partial hospitalization program, or inpatient psychiatric admission. There's different levels. We're going to talk about that. Arrange transfer if the hospital has no psychiatric unit or no available psychiatric bed. See, I don't know that much about her case to know exactly what happened, but I know enough about getting treatment to know what is going on in the US or what might be going on in the county that you live in. When you go to the emergency room in crisis, advocate for yourself. Use direct, concrete language rather than minimize. Don't minimize, such as I'm having suicidal thoughts and I do not feel able to keep myself safe outside of a supervised setting. Be very clear about that. I'm requesting a voluntary psychiatric admission or crisis stabilization bed. Add the facts that affect the level of care. So these are the difference, depending on what you say, when they're assessing you, then they decide what level of care you need. I have a plan. I do not have a plan. I have access to firearms, medication, or other means. I do or I do not feel confident I can follow a safety plan. Because if they release you from the hospital with a plan instead of a stabilization bed, if you can't follow that plan, you need to tell them, I won't be able to follow that plan. I won't be able to go home and, throw out those medications, or I won't be able to give my firearm away, or I won't be very clear. Because remember, you're going to get treatment and you're going to get stabilized. So it's real important to do what you need to do, and if you can't be clear about it, to the person who's doing the assessment. Or you could say, my symptoms are worsening. I'm not sleeping. I'm using substances. It's not unusual for people to use substances and abuse substances when they have a mental illness or they're in crisis. 80% of people that are addicted to substances, drug addiction, have an underlying mental illness. Now, healthcare professionals and even mental health care professionals sometimes don't even know that it's true. So don't feel stigmatized if you mention that, because you're self-medicating because you're not stable. So it's real important to let them know what you've been taking, even if it's unprescribed, and bring your medication list with you. Or I can't get a timely outpatient appointment or safely wait for one. Don't exaggerate or fabricate symptoms. Be accurate, specific, and unambiguous. Before leaving the hospital or the psychiatric ward, ask for a plan in writing. They did give her a plan. They did have a plan. I don't know whether it included not leaving her alone, because they didn't think she was at risk of hurting her children. Had she said that, her husband would have been instructed that she couldn't be left alone. So when he left is when she did the crime. So that's why it's real important to be very specific with what your issue is or you're not going to get help. Similarly, if you're depressed and you're seeing a therapist, you should be able to trust that therapist. If you don't, then you don't have the right therapist. Then you need to find a different therapist. But let's say you have a good therapist and you trust that therapist and you're not being honest about what's going on. You're not going to get the right treatment. Be honest. That's not the time. That's exactly what a therapist is, so that you can you have emotional support. Let's say you have a parent that's very critical and you're 20 years old and you can't tell them that you're having feelings of suicide. You can't tell them you have a plan. You don't feel comfortable because they'll criticize. You can't tell them, let's say you're having symptoms of bipolar or psychosis, and you don't feel comfortable telling your partner or your parent or your husband or your wife. You should be comfortable telling your therapist. That's the whole point. So don't keep things out of your therapy appointment. So a collaborative safety plan that identifies warning signs. So they'll discuss what will be the warning signs that, that might come up, and what are you going to do if that comes up. And then you both develop a plan of what you're going to do if that comes up. Let's just say, for instance, lethargy. You're just really tired all the time. You can't get this done. What could you do to alleviate that? Take a nap during the day, or I'm just giving an example. But so when a symptom comes up, you have a list of what you're going to do or who you're going to call. Or let's say you leave the psychiatric ward, you don't have feelings of completing a suicide any longer. What are you going to do if that comes up? Who are you going to call? What are you going to do? So that's part of your safety plan. You should have a lethal means safety plan. Who will secure the firearms, medication, sharp objects, or other dangerous items, and where? I think I'm not sure about knives. It wasn't in our list of the top 3 suicidal, but you can cut your arm. So if you're at risk if you're at high risk, and your safety plan could involve removing sharp objects. So don't forget about sharp objects. Yeah. Or other dangerous items. A scheduled, not merely suggested appointment. Ideally within 24 hours, as soon as clinically possible. Rapid follow-up is what they recommend. The name and direct number of the outpatient clinician program. Clear instructions for when to return to the ER or call 911 or 988. You can call or text 988 when in crisis, and there will be a support person to talk to you and help you figure out what you're going to do, where you're going to go for help. A follow-up call or caring contact if the service offers it. At the emergency room, suicide care guidance recommends safety planning, lethal means counseling, and rapid follow-up care. Evidence reviewed by SAMHSA found safety planning plus follow-up associated with fewer subsequent suicidal behaviors and better treatment. So it's an extensive plan that you're supposed to follow and agree upon. If you don't agree upon it, then you shouldn't leave until you have a complete safety plan that works for you to be an outpatient, especially if you're not that stable. And we'll talk about that. The reason why I bring that up, you can be released from a psychiatric ward for a short-term stay and not be stabilized because there's a shortage of beds. So we value more outpatient treatment here in the US than in Australia, which is a comparable country to population and size. Bed shortages for psychiatric beds. The United States has fewer psychiatric beds per person than Australia under several comparable measures. A commonly cited U.S. estimate is 28.4 inpatient psychiatric beds per 100,000 people in 2023, compared with 40.9 per 1,000 in Australia. An Australian analysis using broader hospital bed counts. So we don't have as much beds. We have 28.4% to their 40.9%. They don't have, when you go to get assessed and you're in crisis at the emergency room, they don't look for a short-term hospital stay or a psychiatric bed or long-term, or they don't do that. They admit you to a psychiatric hospital, and that hospital monitors you until it's safe for you to leave. The reason why we have categories of what you say matters and what type of bed you're going to get and what your stay is going to be is because of insurance. Similarly, like if you want to have a test run with your family doctor and they don't want to do that test because your insurance isn't going to pay for it. So it could be from insurance purpose reasons why we do it, but we certainly have a bed shortage, and that's why we do it, period. We have a bed shortage for psychiatric beds. I know people that have long-term, serious, persistent mental illness that often have to go in to the psychiatric hospital to get a bed, and they have learned how to advocate to get a bed when they need one. You know, one particular person, she was peer support that I worked with at the county mental health center, and she frequently, you know, every year, every couple of years, but every year, at a certain time of the year, she would get really sick. And she had a serious, persistent mental illness. So she knew what she had to do. She worked at the county mental health center. She was peer support. So she did help others that had serious, persistent mental illness, which I don't want to forget this either. But if you're getting treatment for depression, anxiety, mental illness, newly diagnosed mental illness, or a serious persistent mental illness, peer support, there's support groups in your area. Look up, call the county mental health center, call what's in your area that treats people for mental illness, and see what type of peer support groups they have. That's the best way that's a good tool to have in your toolbox, because when you go to those support groups with others with the same, let's just say it's a bipolar support group, those that have bipolar disorder are in that support group. Some of them for years, some of them are new. They can tell you how to navigate that illness and what they did. You can help each other to gain insight on your illness, and discuss and get emotional support, peer support from someone that has gone through it or going through it, similar to Alcoholics Anonymous. So it's a good tool to have in your toolbox. You're suffering from depression. Look and see if there's a depression support group. We used to have a group for family and friends of people with serious, persistent, or mental illness. So family members, it was once a month for an hour. friends or family could go to that group, and there would be a licensed therapist there, there's running that group. So there's lots of groups. Look them up. Now they're all online, so you can do virtual ones now, which is fantastic. It could be in another state. It could be the perfect group you're looking for. It doesn't have to be. You don't have to go face to face. Now Australia has universal health care. So they don't have those, problems with your insurance doesn't cover this or that. We have that here, and we have people without insurance, and that's a barrier to getting treatment. And we're going to discuss that more in detail. Yeah, Australia doesn't use a universal short-term, long-term rule. A person remains in acute psychiatric unit only while they need hospital-level treatment, and no less restrictive safe option is suitable. A longer stay generally reflects unresolved severe symptoms, ongoing danger, or lack of safe discharge setting. Australia's average mental health inpatient stay was 14.3 days in 2022 to 2023. So both 4 and 30 days are plausible, but represent different clinical situations. So we don't really know, but they do assess differently because of our shortage of beds. I'm sure of that one. That's my opinion. In the United States, the initial crisis assessment often includes a placement decision between short-term acute hospitalization and a longer-term residential or step-down program. So that happens during your first assessment. They decide where you're going to go. Where it's different in Australia, it's the same place. You go to the same place. And they're assessing you every day and making a decision, and they have more beds. So their decisions might be more accurate than ours. We used to have facilities, huge facilities for the deaf, the dumb, developmentally disabled. That's what they called them. And people with psychiatric problems, mental illness, they were all grouped together in one institution. And every state had 2 or 3, depending on the size of the state, and everybody just had to go there. So you could have a developmental disability, or you couldn't speak properly, or you were deaf, or everybody was grouped there. So there was a big push in the 50s to close those institutions because advocates for the disabled advocated for them to be closed. So they did close those institutions, but what they didn't do, so those, instead of everybody in that group being in an institution, they could have a case manager help them live on their own in an apartment, or they could live in a small group home setting in a community. So they could be in a group home right in my county somewhere and be able to go to the shopping when they want, or do whatever, depending on what level of care they needed. So it was good for that, people with developmental disabilities. And of course, we know people that are deaf, they don't need to be institutionalized. They learn sign language, and they can, fit in very well with the population, but they were put in those institutions too, because they didn't have sign language, and they, couldn't learn effectively because they didn't have a language. With sign language, they could learn a language at a young age and get highly educated and function. So, but what happened was, getting mental health treatment fell short. Carter wanted a program that would going to address that. People needing mental health treatment and, funds for that. But when Reagan came in, he nixed that program that Carter wanted. It's in my references if you want to look it up, what happened, but it kind of fell short. And that's part of the reason why we have a shortage of beds. Also, Reagan took the federal funding for mental health care and gave block grants to each state, depending on their size. And then the state would decide how many mental health beds or what type of mental health care, treatment they were going to give, depending on their size. But they have competing budgets with other things. So it not being a federal, universal thing, depending on what state you're in, your level of getting treatment for mental health is going to be different. So if you live in one state and you don't have a mental health problem, or you do, let's just say, and you want to move to another state, you need to check that out because they could be better or less. So you'll have to do your research on that. So the states are not all universal because it's not a federal program. At least that's what I read. So I have the references in my notes. Yeah, the problem was not simply closing old hospitals. Many places failed to build the community services and treatment beds intended to replace them. What should replace institutions? A functional system needs a full continuum of care, community-based disability services and supported housing, emergency psychiatric evaluation when someone may be unsafe, short-term crisis stabilization programs, acute inpatient psychiatric treatment when needed, step-down residential or partial hospital programs, consistent outpatient treatment, medication follow-up, and family support. That's what we have in our county. But it's falls short because we have a shortage of beds. And every county is going to be different. And I can also tell you, I worked at the county mental health center where I live for several years, and every year it changed based on funding. So we might have a robust system one year, and then the next year, the people that qualify for services at the county mental health center, the salary rate gets shortened. They have to be really low income to qualify or really severe. So your income and your severity decides whether they will start treating you. Well, it would change from year to year. It would drive me crazy. So that's a barrier to getting treatment. It's not consistent. We don't know because it's not a federal, the subsidies are not federal mandated and the same consistently from state to state. So that is a barrier. Okay. Let's talk about common symptoms of depression, because a lot of people may be depressed and not know they're depressed or not put point a finger at what's going on. Persistent sadness, emptiness, hopelessness, or frequent crying. Now, you might not know that you're sad, or you're sad, but you're not putting your finger on it. So you could start a diary to start addressing those feelings. When you start addressing them on paper, you might notice a pattern and you might say, you know what, maybe I am depressed. And it could be a change in your life, a life-changing event, anything to do with court, a divorce, having a baby, a death of a loved one, or it might have nothing to do with that. Um, but we're going to go over the symptoms: sadness, hopelessness, emptiness, frequent crying, feeling emotionally numb, detached, or unable to enjoy things, loss of interest or pleasure in hobbies, relationships, sex, or ordinary activities, irritability, anger, anxiety, agitation, or restlessness, low energy, exhaustion, slowed movement, difficulty initiating even small tasks, sleep changes, insomnia, early waking or sleeping far more than usual, um, appetite or weight changes, eating much or less than usual, trouble concentrating, remember thinking clearly or making decisions. And you might notice these symptoms in your loved ones, and you can write those down so that when you do go with them for an assessment, you have the symptoms written down. Excessive guilt, shame, self-criticism, worthlessness or helplessness, social withdrawal or reduced communication. So let's say you're a teenager, you're a parent, and your teenager is socially active, in all these groups, and all of a sudden they start withdrawing from that social group. That's a sign. And you'd want to talk to them about it. If you're a parent and you're judgmental, your teenager is not going to open up to you. So you need to be careful about your script when you're asking them, I noticed that, you're not going to that group anymore, or you're not hanging out with your friends anymore. What's going on? How are you feeling? So practice with a friend. If you're very judgmental or critical, write down your script, plan, practice, learn how to not be judgmental, because it's not good for teenagers that are high risk for suicide. They won't open up to you. And sometimes they won't open up to their parent anyway. You might not be the right person to give them mental health first aid. It might be a friend that they open up to. So you could ask one of their friends, call them and say, "Hey, can you find out what's going on with Sarah? Because I noticed this, that, and the other." You could enlist somebody that's closer to that person that might want to open up to that person to find out what's going on. Sometimes you're not the right person to get them mental health first aid. There could be physical symptoms without a clear cause, such as headaches, body aches, problems, or reduced libido. Some people, they feel sick all the time, but there's no real cause for it. It could be depression. They seem to notice every little thing. It seems to be amplified. Like, we all have aches and pains, but it's more amplified when you're depressed. And of course, thoughts of death, self-harm, or suicide is a symptom. Postpartum depression can include the same symptoms, plus feeling distant from the baby or having difficulty bonding, doubting your ability to care for the baby, feeling overwhelmed, fearful, intensely anxious, or feeling like you're a bad parent, thoughts of harming yourself or the baby. Feeling emotionally flat or numb can occur with depression, but it can also occur with medication effects, trauma, dissociation, severe stress, sleep deprivation, or other conditions. Sleep deprivation, I'm saying it right, can cause a mental health crisis if you haven't slept in days and weeks. But it does not automatically mean depression or psychosis. Family members should take changes seriously, especially when they are new, escalating, or follow a major stressor, loss, medical change, or medication change. I remember my neighbor, and I wasn't that close to her. She was my neighbor, but we weren't real close. We didn't hang out together or anything. And one day she had a baby 3-4 months later, 6 months later, I can't remember. And she was seeing things. She told me she was seeing something. She was seeing things like images at the bank when she went to the bank. That's how long ago it was when we went inside the bank. So she was starting to see things. Anyway, I called her husband, or I seen her husband later, and I go, "What's going on?" And he goes, "I don't know what you're talking about." He didn't even know that she was having all these mental health issues. She told me about it and didn't tell him. So that can happen. So if you're a partner or you're a husband of, and your partner just gave birth, start paying attention and take mental health first aid so that you can see the warning signs and know how to help them. So there's many reasons for depression and suicidal thoughts. We talked about a few of them, but one thing that I want to bring up, because it did happen to me, there's a Danish study. They tested over 600,000 women that had postpartum association, and they were 1.49 times higher for risk of depression compared with not using birth control pills. So the ones that use birth control pills were 1.59 times higher than those who didn't for risk of depression. The study didn't study progesterone only. It was a combination pill. Now, after I had my son years ago, I can't remember, it was a couple months after I had him, I had affect emotion. I was just like blank. I wasn't happy, sad. I couldn't put my finger on it. Well, my sister, who's a retired pharmacist now, was a pharmacist at the time, and I told her, "There's something wrong. I don't feel right." And, I told her what my symptoms are, and she said, "It's the birth control pill. Stop taking it." Who would have thought the birth control? After I stopped taking it, within a couple of days, it went away. Of course, you got to use a different type of means for birth control. But according to this, there's no other study about it. There's warning labels on the pills, but who reads the warning labels? Start reading warning labels, sign, and symptoms when you get a new prescription of anything. Who would have thought? Can you imagine? And who knows how long that, and I always worry about women on birth control pill because it's just not widely known. Apparently, the study is low risk, but not taking your medications properly can be a side effect of, having mental health symptoms. And it could be your antidepressants, of course, but it could be your prescriptions for your body too could cause a change in your mental health. So I highly recommend, and most people that are on psychiatric medications, at least that I know of, when I worked for the county, we had a pharmacy in-house. So when they got their pills, it was a 30-day pill pack. So when they took their pill, they knew they took their pill. Just like a birth control pill, you took your pill. If you don't have that, when you get a prescription for something, mental health medication or for your physical health, get a Monday through Sunday pill container. So when you take it later on in the day, you can say, "Did I take my pill?" You can go and look and see if you took your pill. There's no mistaking it. I highly recommend that. There's medical reasons too. So you can get help simultaneously before or after with your family doctor. Let your family doctor know that you're having symptoms. Um, they can order blood work. So we're going to go over some of those physical health conditions that could affect your mental health. So you want to outrule that. Don't keep yourself from going to the ER to get assessed if you're having a mental health crisis. You can always go later. So you're going to do that at some point before, during, before or after, but you want to let your family doctor know so they can outrule medical conditions. So thyroid disorders can cause depression, fatigue, slowed thinking, memory trouble, anxiety, agitation, insomnia, hypothyroidism, and it can produce low mood and cognitive slowing. So you might need to get your thyroid checked. Tell your doctor what your symptoms are. And tell them you want some blood work, you want a health evaluation because these are my symptoms. And they should know what to test you for. Anemia or iron deficiency can cause fatigue, weakness, breathlessness, dizziness, poor concentration, irritability, or low mood. Vitamin B12 or folate, malabsorption, pernicious anemia can cause fatigue, depression, brain fog, memory problems, tingling, numbness, balance changes. Severe B12 deficiency can cause neurological and psychiatric symptoms. Vitamin D deficiency can cause low sun exposure, diet absorption problems, because vitamin D is in I think dairy, or if you don't get enough sun. It's associated with depressive symptoms, fatigue, too. So the doctor might want to check your vitamin D levels because we're told to stay out of the sun. My vitamin D was always low. I always had to be on vitamin D. Sleep disorders. You could have sleep apnea, chronic insomnia, restless legs. It can cause depression, light fatigue, irritability, impaired concentration, anxiety, mood instability. Hormonal reproductive conditions, postpartum hormonal shifts, perimenopause, thyroid disease after pregnancy. You can have mood shifts, anxiety, insomnia, depressive symptoms, need for medical and mental health assessment together. You should do them both. Get an assessment for your mental health and get a physical for your physical health. Medication or substance abuse, steroids, stimulants, sedatives, benzoids, benzodiazepine withdrawal, some anti-seizure drugs, alcohol, cannabis, illicit substances, drug interactions, depression, agitation, insomnia, anxiety, mood swings, confusion, hallucinations, or psychosis, depending on the exposure. When you start taking your mental health medication, I'm not sure if I mentioned this, but if you're depressed and your psychiatrist puts you on an antidepressant, or your family doctor, look at the warning signs on the label, write down, get a mood tracker, write in your notebook your signs and symptoms, and get one of those pill things so you make sure you're not taking them, so that you make sure you're taking them every day. If you do not take them properly, you could have an adverse side effect. Now, Lindsay Clancy, they withdrew her for some medication, and I'm sure they titrated her down. A lot of that medication, you have to be titrated down. But it still can cause your symptoms to be worse while you're titrating down. So you definitely want to track your symptoms and take note of that. You can't just stop taking an antidepressant. It can cause a severe crisis. And you can't decide that it's not working and you want to stop taking it. You have to contact the doctor that prescribed them and let them know you're having severe side effects. Don't just abruptly stop taking them. Metabolic illness, diabetes, electrolyte disorders, kidney, liver disease, low blood sugar. I have an electrolyte disorder. So, fatigue, confusion, cognitive changes, anxiety-like symptoms, mood symptoms. I have neurological disorder from my electrolyte disorder. So I sometimes can't pronounce things properly. So getting assessed by your family doctor could be part of your plan. Read the inserts on your medication. No changes when you started medication. Medication adjustments can be an important risk factor, especially if they coincide with insomnia, agitation, suicidal thoughts, psychosis, mania, confusion, or loss of functioning. Now, I am covering the other high-profile cases: Tyler Robinson, Luigi Mangione, Nancy Guthrie. After most of my videos, there might be one or two that I forgot. At the end of the video, I give you a mental health tip. And this is why, because I used to be a youth mental health instructor. So I will continue to do that after each video. I won't today because I'm giving you lots of tips. Now, what I find, this is just my opinion. There's no documentation about it. It takes 30 days for your medicine to start working. But when you stop, my experience, when you stop a medication, even when you titrate it down, the doctor prescribes a long titrate. It can take weeks before you start feeling improved. She was released. She was on really strong psychiatric medicine, and she was released in less than several days, 4 or 5 days. That to me. But she was supposed to have this safety plan. They want you outpatient. They expect your family to do this and support you. And so you're getting treatment, but it's outpatient because it's cheaper because we don't have enough beds. So that's just my personal opinion. She should have been in the psychiatric hospital bed for weeks and months. What was the failure? The failure was, part of the problem is our system, and part of the problem is she did not tell them. She thought her children would be taken away. She wasn't thinking straight, though. So her husband maintains, and the defense attorney maintains, they didn't do a proper evaluation. You make your own decision if you're following the case. How to advocate yourself if you had a change in medication and you're going in for an assessment. The medication change is causing or may be causing specific unsafe symptoms. The patient, your loved one, or I cannot safely manage this at home. Advocate for yourself if you feel that you need a bed. We are asking the treatment team to document why a less restrictive setting is adequate or to refer me to continuing care, residential care, partial hospitalization. So tell them to document it, why they think that a less restrictive setting is better for you. Ask for documentation because they have to have discharge papers and a plan for you. And you want that all in writing. They can say, please have the on-call psychiatrist or licensed mental health clinician reassess me. So you can say, I want another assessment. What suicide risk level did you assign? And why do you believe outpatient care is safe? You could say that. Please document that I requested voluntary inpatient or crisis stabilization care and the reason it was declined. Get it in documentation if you feel that you should not be leaving. Is there a crisis respite residence, crisis stabilization unit, partial hospitalization program, or 23-hour observation unit available today? You can ask that. Can you call a family member support person in this discussion with my consent? So let's say you go by yourself and you're not happy with the discharge. Can you call my mom or call my dad or call my sister or call my friend and bring them into the discussion? You're not being difficult. You need clear reasons, safety planning, and a workable level of care alternative that's appropriate for you. You know what's appropriate for you. Ask in writing. Just make sure you get everything in writing. Okay. How to help a friend or family member if you notice a change in behavior. If they say they want to die or kill themselves, disappear, or have no reason to live, saying they feel trapped, hopeless, like a burden, ashamed, or unbearable emotional, physical pain. They're looking up methods, stockpiling medications, buying a weapon, or otherwise making a plan. Giving away possessions, saying goodbye, putting affairs in order. Putting affairs in order and giving things away is a silent symptom. They may act like they're fine to everyone else and not tell anybody, but they're starting to give their possessions away. And they're contacting people they haven't seen in a while so that they can say goodbye to them. They're getting documents, wills together. They're withdrawing from family and friends, work activities they normally value. They're having sleep or appetite changes. So even if they don't say anything to you, these are things that you can notice, because people that have completed a suicide, sometimes their family members had no idea. But these are warning signs that you can look for and notice. And when you have the course, Mental Health First Aid, they go into detail. They role play on how to ask the loved one to get them into treatment, to talk to them about what's going on. You know, like they say, I've noticed that you haven't been sleeping lately. I've noticed that you withdraw from your friends. And then do open-ended questions. So when you say something, cut it off so that they can talk and tell you. Don't ask them yes or no questions. So that'll open up the dialogue a little more. The extreme mood swings you might notice. Repeated talk or fascination with death. She had a fascination with death because I think a friend said that she was fascinated with one of the cases that were similar to hers. She had talked about, they brought it up in court. So she had that was her symptom. For a new parent, urgently act on any statement about harming themselves or a baby. Severe insomnia with escalating behavior, hearing voices, paranoia, confusion, or losing touch with reality. Do not leave that person alone with the infant. Call 911 or go to the ER. Now, when I used to assist my supervisor in teaching mental health first aid before I became a youth mental health first aid instructor, but they had a video on how to help somebody that was in psychosis that you would watch in the course. And it was about 10, 15 minutes long, 20 minutes long. And this person is in psychosis and they're seeing things. And a neighbor is trying to help them contact their case manager or their therapist. And there's a whole video on it. I don't want to remember the details of it, but that's how important that course is. It goes into detail. It's a detailed course. I highly recommend it. Ask open-ended questions such as, I notice you've been crying a lot. What's going on? Or not sleeping or distance from the baby. Listen patiently to their feelings without interrupting, judging, or offering uninvited solutions. Give reassurance and information. Provide emotional support. Affirm that help is available and treat them with respect. Encourage appropriate professional help. Guide them towards resource sources such as a therapist, counselor, doctors, or crisis lines. So giving them resources, here's the number to the county mental health center. You just call and they'll do an assessment over the phone. You might be able to get an intake or just walk in. They have triage there anytime from 9 to 5. I'll go with you if you want. They have triage there at the county mental health center. You can just walk right in. Or there's a psychiatric hospital 30 minutes away. I'll drive you there. We can go get an assessment, or we can go to the emergency room at the hospital and get an assessment. Or I found a therapist that takes your insurance. Get resources. And another thing about giving them resources is, depending on who they are, it could be financial resources. 211 Connect. Let's say that person doesn't have heat and they need a new furnace. You can call 211 Connect and they'll let you know what grant funding is available to get you a furnace. You can call 211 Connect to get resources for a crisis psychiatric hospital. You can call 211 to get any resource. It's a nationwide number, and they'll send you a list of resources in your area for whatever it is you need. It could be if you have a physical illness and you can't take care of yourself and you need some help taking care of yourself, they can give you all the resources with that. There might be some grant funding for that. They can give you resources to apply for certain types of insurances that might cover what you need. So 211 Connect is a resource. 988 is the crisis line. If the risk is current and you cannot reliably stay safe or you need an assessment today, just go to the ER. Some hospitals have a psychiatric unit, some don't, but they all are supposed to do a mental health assessment. If there isn't one on staff, we would, at the county mental health center, we always had somebody that was on call that would go to the hospital. So we had 24-hour on-call therapists that would do triage at the hospital and just go there. And we had a psychiatric ward at the hospital. And I can tell you, a friend of mine was having feelings. He had a medication change and he was having these weird thoughts and he wanted to hurt somebody. And he was in mental health crisis. And he said, what do I do? I said, go to the county mental health center and do a triage. They didn't want to admit him and he needed a bed because wanting to hurt somebody is not good. So he went to the emergency room and he brought his mother with him, and he advocated for a bed. And you know what they told him? You don't want to be in that on that ward. It's not pretty. They talked him out of it. I don't know what he said or told him. I just know that he was in crisis, and I told him to go to triage. And triage he wasn't happy with whatever it was they told him, and he went to ER, and he did get a bed. And he was there for several days at the hospital because they had a ward. They had a psychiatric ward until his medicine was stabilized. Not all hospitals do. It depends on what area you live in. But they'll refer you to the closest psychiatric hospital that has a bed. Call or text 988 if you're in crisis. They're available 24/7. They can help you decide whether to go to ER, connect your local mobile crisis services, or locate a crisis stabilization inpatient option. Call a psychiatric hospital or crisis center directly. Ask, do you have a voluntary admission intake and an open stabilization bed? Some facilities can screen and admit directly. Many will direct you to an ER first. Call your psychiatrist, therapist, primary care clinician, your gynecologist. Tell them you need an urgent assessment and a referral. Do not wait for a routine appointment if you cannot. Stay safe. And if you do not have insurance or a way to pay, that's irrelevant. What's decides whether it's urgent is your symptoms. When a person is willing and able to consent, voluntary hospitalization is preferred. For acute, moderate to high suicide risk, an assessment will still comes first. A request for a bed does not guarantee admission, because the team must determine the safest appropriate level of care and find available capacity. You could be in an area where there are no beds and you could sit in the emergency room. I don't know. Inpatient care usually provides monitored safety, psychiatric assessment, medication review, individual group programming, and discharge planning. It is meant for immediate stabilization, not a complete long-term therapy program. Follow-up care after discharge is crucial because risk can remain elevated during transitions. So your safety plan, you want to agree on that before you leave. But yeah, your risk can be elevated. What Lindsay Clancy should have done, but she wasn't thinking straight. So she relied on her support team. So her mother and her husband, had they had mental health first aid, and she said she had feelings of wanting to hurt herself, when she was discharged, they would have told them when she went in for her assessment, number one. And when she was released, they wouldn't have left her with the children. She would have stayed with her mother until she was better. She wouldn't have been in the same house with the children. So she didn't want that. She even said she wanted to go home. She was feeling better, I think she might have said, or she didn't want to miss an event with her daughter. But she wasn't thinking right. And I think the defense claims she was in a postpartum psychosis. That is what is at dispute. A forensic psychiatrist said, because the prosecution tried to cross-examine the forensic psychiatrist and say, she said she wanted to go home or something like that. And she didn't say that she wanted to hurt her children. And he said that's because she wasn't thinking straight. If she was thinking straight, if she wasn't that sick, she wouldn't have done that. So that was a good answer for him. He didn't miss a beat. So inpatient care usually provides monitored safety, psychiatric assessment, medication review, individual group programming, and discharge planning. It is meant for immediate stabilization, not a complete long-term therapy, follow-up care after discharge. Yeah, there's a shortage of beds, though. Trust me. Inpatient care usually provides monitored safety, psychiatric assessment, medication review, individual group programming, and discharge planning. It is meant for immediate stabilization. A hospital may decide that ongoing care can safely occur outside the acute unit, but then the discharge plan should be specific. So let's say you go to ER and they assess you and they say, oh, you're able to go home now. Make sure that discharge plan is very specific and that you're able to do it. It should have medication instructions, appointments, crisis triggers, and a step-down service such as partial hospitalization. Another thing that you can do if somebody is depressed and feeling hopeless, mild, and they're not in crisis. They're not having feelings of suicide, and they're just depressed. Help them connect with family and friends, community networks, join a group, join a club. People can get depressed that live alone, and they don't know where to meet people. They don't have any friends. They can join a group, like a chess club, or they can join a book club, or something where you meet with people, or and you can help them with that resource. You know what? You love to do this. I found a really good group that you can go to, or church. If they're religious and they have a faith and they don't go to church, you can say, you know what? I found a really cool church over so and so. You want to go on Sunday? Or this is, they even have Wednesday mass in the evening. Take a class, join a group, learn a new skill, help yourself. Self-help. If you don't have any support, help yourself. Do some self-care every day. It could be taking a bath. It could be getting a massage. It could be taking a cooking class and learning how to eat better. Eating healthy is good for your mental health. If you're not getting vital nutrients that your brain needs to function, that can affect your mental health too. So make sure you're eating, nutrient-dense foods. Replace them with processed foods. Okay, to assess for risk of suicide or harm, observe the person for severe distress and determine if they are in immediate danger of hurting themselves or others. Ask them directly. When you have mental health first aid, you learn how to ask. You'll ask your partner that's sitting next to you, because we had face-to-face classes. I'm sure they do it in their virtual classes. You're going to learn how to ask somebody, are you thinking about killing yourself? You need to get comfortable with asking a loved one, a friend, or a family member, are you thinking about killing yourself? Asking does not put the idea in their head. It opens up the discussion so you can find out the level of risk. Do not, if they tell you yes and they have a plan, seem intoxicated or severely agitated, then that's an emergency crisis. You want to call 911 or take them to the ER. Reduce immediate access to lethal means. Secure firearms, medications, and other dangerous items. Call or text 988. You can call for them. You can call or text 988 yourself. You can call for guidance even when you are worried about someone else. The service is free. Call 911 and take them to emergency if there's immediate plan, attempt, weapons access, severe intoxication, hallucinations, danger of confusion, or an imminent threat to themselves or anyone else. If no risk of suicide, go directly to a therapist, psychologist, psychiatrist. If the main issue is persistent depression, anxiety, trauma symptoms, grief, compulsions, relationship violence, addiction, mood swings, or worsening function, even if you also have a plan to see your family doctor. Looking for a therapist. All therapists are not equal, just like all doctors. Look at reviews. look at their specialty. If you had trauma as a child and you've never gotten therapy for it and you decide, now's the time. Some of them have certification in being trauma informed, I think they call it. I don't remember. I think it's called trauma informed. And they have several certifications. They specialize in therapy for those that had trauma. So you could be having marital problems. You want to see a therapist that specializes in marital problems, family counseling, a family therapist. You have a substance abuse addiction. You want somebody that specializes in substance abuse. They have certifications for that. So, now private therapists don't always do a full intake. So you can make an appointment. Let's say, your situation is extremely complicated. You've had childhood trauma, you've got depression, anxiety, and you're just now trying to get help. And it's gone on for a long time. You really need an intake. There's an organization called Catholic Charities where I live, and there's several of them. And you don't have to be a Catholic to go. But they do a complete intake for an hour, and it's like a 10-page paper that you got to fill out, all about your parents, whether you've been molested, raped, beaten, hit, anything that happened in your childhood, any of medical conditions. Have you had any suicide attempts? They do a complete intake. I highly recommend finding a place like that if your situation is complicated, because they know everything about you before your appointment. It's a complete intake, just like an assessment. So when you go to a private therapist, they may do you can ask, do you do an intake? Just like you go to a doctor, a specialist, and they don't want to know your history. Drives me insane. They don't care. Some therapists don't care. Well, if you've got a complicated health issue, you want a specialist that knows your history or does a good intake. Very few of them do. My internist did. She did a lengthy intake. She wanted to know what family members' disorders they had, and what my parents, what their medical conditions were, so that she could help assess me. That's a good intake. But she's an internist, so that specialists don't always do that, but they should all do that, in my opinion. Same thing with therapists. You want to shop around if you can. Shop around. And if you start seeing a therapist and you don't trust them or you're not happy with them, just like a doctor, look at the Google reviews. It tells you a lot before you spend the time if you're shopping around. If someone may harm themselves or someone else has a suicide plan, intent, hearing voices, confused, or can't stay safe, they should call or text 988, call 911, or go to the nearest ER. We've said that several times. And we said Lindsay Clancy feared she would lose her children, or stigma. There's a lot of stigma attached with mental illness. Not as much now as it was in past years. Teenagers all talk about mental illness now, and it's not as stigmatized, but it can be stigmatizing for some people. They don't want others to know that they have a mental illness. Some people have a severe mental illness and don't want to take their medication. And they don't like the side effects. They don't like how it makes them feel, or for various reasons, they don't want to take that happens a lot. Yeah, she was assessed at low risk when she left. Um, Suicide deaths occur across every age and gender group, but the highest death rates are among males, especially men age 75 and older. That is the highest risk group. Sometimes they lose their spouse, they just don't want to live anymore. Um, so if you have a father or an uncle, um, and you notice any of the things that we talked about, giving things away or not sleeping or any change in their behavior, they could be at risk, and you might want to ask them, and you might want to get them help. But you should never judge their that individual person based on these statistics we're going to talk about, because each individual is different. So age 10 to 14, the rate of completed suicides was 2.1 for females, 2.5 for males. Age 15 to 24, 5.5 for females, 21.2 for males. The rate jumped higher for young men than women. Age 25 to 44, the completed suicide rate was 7.7. For men, it jumps to 29.8. From age 45 to 64, female completing suicide is 6. And for men, it jumps to 29.2. 74 for female risk of completing suicide, not risk, completing suicide was 6.2. For males, it was 26.5. And 75 plus females that completed suicide was 5.1, and males that completed suicide was 40.7. It jumped really high. Now, we don't really know. We haven't done studies on why. We can speculate that, men don't have the support system with talking with their friends as deeply as women do, could be a possibility. Whereas women share more with their female friends. They may have more access to firearms. I should have looked that statistic up. Maybe more men have firearms, because this was the statistics on completing a suicide. So they have more access to firearms. They may have more firearms. Less women might have firearms. But yeah, so men are at higher risk. The 2023 CDC base data shows an overall suicide rate of 22.8 per 100,000 for males versus 5.9 per 100,000 for females, nearly a fourfold difference. That is not to say, like we talked about, that a female may not have a plan and have feelings of completing a suicide. So you don't use these statistics to decide whether they need to go to ER for an assessment. The highest female suicide death rate was among women 45 to 64. For males, it was people 75 and older. I wonder if it has to do with menopause, because they have hormonal changes or just changes in their family situations. Empty nest syndrome with their children leaving the nest can be a big change for females when their children start going away, get married, have their own children. They're more distant. It can be a big change. Important distinction, deaths by suicide more common among males, particularly older men. Yeah. Suicidal thoughts and non-fatal attempts. These do not follow the exact same pattern with women and adolescent girls often report suicidal thoughts and attempts at higher rates, while men more often die by suicide. So girls and women reported suicidal thoughts more than men, and men died by suicide more often. So they're less apt to report it. So when you're noticing changes in a male, you want to have that conversation with them about, are they having feelings of hurting themselves? So if you notice any changes, sleep disturbances, withdrawing from their friends or families, giving away things, changing their will, updating things, making big changes, you want to have that conversation with them. And if you're a mother and you can't have that conversation with your son, or they won't open up to you, ask a friend that they feel comfortable with to ask them to talk to them. They might be more apt to disclose that they're having feelings of hurting themselves. They may feel, men may feel weak to admit it, just like Lindsay Clancy felt that her children would be taken away from her. Men may feel that they're weak and they're not masculine because they're having feelings of completing a suicide. So they don't want to talk about it. Okay. Let's talk about the barriers. We know that we have a shortage of hospital or psychiatric beds. Stigma, embarrassment, fear of judgment, or worry that others will see them as weak or an unfit parent. Fear of consequences such as job loss, custody involvement, immigration concerns, or being labeled. Lack of family support, privacy, or a safe way to get care. Symptoms themselves can be depression, can drain motivation and concentration. Anxiety can make calls and appointments feel impossible. Psychosis can impair insight into needing help. Cultural or language mismatch. So, I know at the county mental health center, we had brochures and intake in different languages. So if you're in an area that's a different culture than you have, it could be a barrier to getting treatment because they don't understand what you're saying with symptoms. Some providers, racism or discrimination could exist. Difficulty finding someone who understands your background or your experience. Different cultures have different backgrounds. And therapists are supposed to be equipped to not be judgmental with different types of cultural backgrounds. Other barriers can be no insurance, high deductibles, copays, or out-of-network bills. A plan may technically cover behavioral health, but have few available in-network psychiatrists or therapists. There's a shortage of psychiatrists too. I can't remember what the reason is, but the U.S. has a shortage of psychiatrists. I think has to do with insurance, their liability. There's less psychiatrists going into it. I can't remember what it was. You can look it up yourself, but there's a shortage of psychiatrists. So that appointment that you're supposed to have when they discharge you the next day, I don't see that happening. Where I worked at the county mental health, it took weeks to get in to see the psychiatrist. Not the next day. So tell them you're not leaving until you get it. Make sure you get your appointment. If that's a deal breaker for you, say that you want your appointment first to see them so you can get your medication change or whatever. Put that in your plan. Agree to that. Agree to your plan. If you don't agree, you need to work, they need to work it out with you. But yeah, did she have, because the plan, it says they should have a plan for an immediate appointment the next day within 24 hours. Who can get an appointment the next day? I thought that was weird. Among U.S. women who said they needed mental health care but did not receive it, 32% cited cost. 13% of women ages 18 to 64 said cost prevented them from obtaining or continuing care. There's provider shortages, psychiatrists, child, adolescent, or perinatal specialists. There's long wait lists, difficulty finding a provider, accepting new patients, or a specific insurance plan. They may not take your insurance, especially private therapists don't take all different types of insurances. Some people live in rural areas and they might have transportation limitations. Now everything is, you can do telehealth. You can look for a therapist that does telehealth or a psychiatrist in another state. Now, we didn't have that when I worked at the mental health center, but now a psychiatrist can be in another state and you can have a telehealth appointment with them right from your home. So that might not be a problem anymore, getting an appointment, because you can get an appointment anywhere. For a rural, if you're in a rural area, or you might have unreliable internet for telehealth. You might be you might have persons with disabilities might have a barrier with their disability getting to clinics. Limited clinic hours if you work during those hours when they're available. Like when I first started working for the county mental health center, we used to be open 2 late nights. And then a few years after I was working there, they cut those hours. And then we were only open, trying to think if it was 8 to 5, Monday through Friday. We weren't open on Saturday, and we weren't open late nights. So that can be an issue. Lack of paid leave, childcare, caregiving responsibilities can be a barrier. Poor coordination. There is poor coordination between primary care, obstetricians, gynecologists, emergency care, therapists, psychiatrists, pharmacies, and hospitals. There's real poor coordination. We had case managers at the county mental health center that you have to qualify to have a case manager. You have to be severe and not be able to manage your life. And you have to qualify income-wise too. But then you get a case manager. This is at the county mental health center. I mean, your insurance might qualify. I don't know how you qualify for a case manager, but it could be income and your severity. But if you have a case manager, you can't manage your life. You'll have a case manager that'll help you manage everything and coordinate your appointments. So we had several case managers that did that where I worked. Brief appointments that focus on medication refills rather than follow-up, side effects, sleep safety, or changing symptoms. Sometimes your appointments are 15 minutes long and they're just talking about one thing when you need a longer appointment. That can be a barrier. Lack of screening after delivery, after you have a baby, and gaps after discharge from inpatient or emergency care. Insurance rules such as prior authorization, limits on visits, and inconsistent provider directories. You don't have that with universal health care. We have that here. So that is there are barriers to getting mental health treatment with the current healthcare system. Practical warning signs that someone may be falling through the cracks include missed follow-ups, rapidly changing medications without close monitoring, worsening insomnia, escalating anxiety or agitation, side effects that are minimized, and a caregiver who says they cannot get an appointment. If there is imminent safety concern, suicidal intent, intent to harm a child, hallucinations, delusions, severe confusion, do not wait for a routine appointment. Call or text 988, go to the nearest emergency room, or call 911. Oh, and mental health first aid has special classes for police, law enforcement, emergency workers. They have special classes for older adults, so for seniors, and they have youth mental health first aid, which is the second largest course that I used to teach. And the other ones are a little bit smaller. But we had an instructor that taught all law enforcement in the whole county that I lived in. She did several courses. They were all trained. So anytime a new law enforcement person was hired, she would train them. And it's a special mental health first aid course. But you have to be certified to teach a special course. Well, once you're certified to teach that course, a person that goes to that course is certified to help somebody in a crisis. They've learned all the warning signs and what to do when they encounter, like, let's say an officer comes to somebody's house and they're in psychosis. They're taught what to do. You can also call mental health first aid. I'll have the link in my summary, and ask about it. See if there's any grant funding for your county that you live in, for your law enforcement to take that course. Because now it's online. So somebody could teach that course in another state, and the law enforcement can learn it online. So there's no excuse. Let's talk about insurance and public coverage. There is some changes in Medicaid coverage with the current administration. I really don't know what they are. You'll have to check into it. But Medicaid, of course, covers low income adults, children, pregnant women, people with disabilities. Rules vary by state. You'll have to apply through the state Medicaid agency in your area. There's usually a portal, or HealthCare.gov. Ask about retroactive coverage for recent medical bills. So ask, once you get your coverage for Medicaid, see if they'll go back and cover bills from a few months ago, because it takes a month for you to get your to get covered once you apply. So they might backdate it. So ask about that. CHIP, children and teens whose family income is too high for Medicaid but still limited, apply through the state. I think it was CHIP that they were trying to take away, but I'm not sure. Don't quote me on it. But CHIP is a program for children and teens. You can go to the portal, HealthCare.gov, or the Medicaid portal to see if you qualify for CHIP or your teen or child. And of course, if you don't have insurance through your employer, the Affordable Care Act, the Marketplace Plan, for those who don't qualify for Medicaid and lack affordable employer coverage, you can contact HealthCare.gov or the state Marketplace. It goes by your tax credits. Depends on what you qualify for or what your out of pocket's going to be. Now, where I live, there's a low income organization that have several offices that treat people without insurance. They have doctors, not for mental health, but we used them for people that didn't have insurance. as their regular doctor for tests for healthcare, not mental health care, but for physical health care. And they had a navigator for the Affordable Care Act at their organization. So we would send people to him all the time. He would come to the county mental health center and see people lined up, and you would tell him what your income was. He would ask you a bunch of questions, and he would help you apply, and he would tell you what plan to pick. He was an expert on it. So I don't know if you have someone like that. It would be an affordable healthcare advocate that you'd be looking for. Let's see. Premium tax credits may lower monthly premiums. Cost sharing reductions can lower deductibles, copays for eligible people choosing a silver plan. Your employer plan, workers or dependents with job-based insurance, compare the mental health network, copays, deductibles, medications, and inpatient crisis coverage before selecting a plan. So you're starting a new job, you have a mental illness, you have depression, and you're starting a new job. Look at those copays, look at the mental health network, make sure that your psychiatrist, your therapist, whatever is in that network, they take that, your insurance, see what the copays are, the deductibles, your medication copays could be more. And if you've had inpatient crisis stays before, you'd want to check that coverage too before you select a plan. And don't forget, adults up to age 26 can be on their parents' plan. Medicare, adults 65 and over, and some disabled adults. Check for Medicare mental health coverage and whether Medicare Advantage or Medigap option changes cost sharing. TRICARE, Indian Health Service, Veteran Service members and families can be eligible too. I'll have all the links to the resources. I read this and I didn't know this. The Affordable Care Act marketplace plans must cover mental health and substance use treatment, including outpatient counseling, inpatient care, and prescription drugs. Purity protections generally require mental health coverage to be comparable to the medical coverage. So it means that if you pick a plan and you looked at the health coverage and you have 4 different choices, one's a lower out of pocket, 2, 3, and 4, it gets a higher out of pocket. The mental health part of that insurance plan should match that. But check for yourself, because if you need treatment for ongoing treatment for mental health care, you want to look at that program. Typically, there's copays to go see a therapist, $30 copay. You need to go every couple of weeks. It's $30. That's $60 a month. It can be expensive. That's a barrier. County or regional community mental health agencies may offer crisis care, therapy, psychiatry, case management, and services for uninsured or low-income residents. Like I told you, where I worked, the income changed every year. It was just a big mess. And we specialized in that. So I just think it was strange. Some therapists do a sliding scale. So they'll go by your income. So it might be cheaper to go by your income for your out of pocket. Ask about it. There's some like Catholic Charities in my area, they're nonprofit. So they're lower priced and they do have a sliding scale. So ask. Charity care, grants, payment plans, or reduced fees for uninsured. SAMHSA notes that many providers offer income-based fees. University training clinics, which I did not know, psychology, counseling, social work, and psychiatry programs often provide lower cost therapy supervised by licensed professionals. Free clinics and nonprofit clinics. Some provide therapy, medication management, or referrals through volunteer clinicians. These are all resources. Not having resources is a barrier to mental health. So you having resources helps a loved one or yourself. Don't be afraid to ask for help. Don't be afraid to call around. Learn how to ask for help. You deserve it. Peer support, we talked about that. Look for support groups that are run by peer support people, those with the same mental illness that you have. If you are suffering from bipolar disorder, look for a bipolar support group. They have so many tips and tricks to help each other out. Bar none, support groups rock. Put that in your toolbox. But they do not replace emergency or clinical care. It's on top of your treatment program, joining a support group. But they can reduce isolation and help people locate services too. Telehealth platforms we talked about compare transparent self-pay fees, but confirm clinician licensing in the patient state, crisis procedures, prescription limits, and privacy practices. So if you're looking for a psychiatrist and they have a telehealth platform, or you're looking for a psychiatrist because you don't qualify at the county level because your income's too high, do some shopping around, find out what their license is, look at their reviews, their crisis procedures, prescription limits, and privacy practices. SAMHSA has a treatment referral line, and it is 1-800-662-HELP. And that'll be in my summary. And FindTreatment.gov can help locate local mental health and substance use treatment centers. Now, if you're on a medication that's really expensive, you can ask for a generic or low-cost medication that's clinically appropriate. Ask the pharmacist about cash prices, discount programs, and 90-day supplies when safe. Ask the prescriber about manufacturer patient assistant programs or samples if available. So let's say your psychiatric medication is really expensive and you can't afford the out-of-pocket for it. The pharmacist or your psychiatrist can find out who the manufacturer is and get a form, or you can contact the manufacturer and ask for a patient assistance program or ask for samples. We used to do that all the time for our clients. They couldn't afford the out-of-pocket. They were in that gap where they didn't qualify for Medicaid, but they qualified for our services because they were so severe and their out-of-pocket was too high. And we would contact the manufacturer and we'd get a form, they'd fill it out, and they would get their medication for free. So don't forget about that resource. Do not split, stop, or taper psychiatric medication without prescriber guidance simply because of cost. Ask for a lower cost plan first. When the prescribing psychiatrist gives you a prescription and finances are an issue, they usually know how much it costs. Find out at that time. Say, how much is that? Can I find out what the cost is before we prescribe that? Or, Is there something that costs lower? Some generic psychiatric medication for antidepressants have more side effects than others. But if you can't afford the other medication, better to get what you can afford. And then, of course, you're going to monitor your side effects while you're taking it until you improve, and you're going to keep your appointments so that you can tell your psychiatrist how you're doing. It's reasonable. Ask a trusted family member or friend for targeted help, especially when the person is trying to begin treatment. You might need help with the copays. Ask a family member if they can help you pay your copay. Ask your mom, your sister, your brother. My copay, I have to see the therapist twice a month. My copay is $30 each time. Can you pay for my copay fees so I can get the treatment I need? Learn how to accept no. If somebody says they can't help you, do not get discouraged from asking somebody else. That is the number one reason why people don't ask for help, because somebody told them no, so they're afraid of being told no. Learn to get over that hump. Ask, ask, ask. Ask for help, especially if you have children. You might need help completing the Medicaid to get Medicaid on the website. Ask someone to help you. Can you come over and help me apply? Or I can't apply for the Affordable Care Act. Can you help me apply? Help finding an in-network clinician, making calls, attending an appointment, or keeping a symptom medication timeline. Help you with making sure you're taking your meds. Help with temporary safe housing or staying with the person during a crisis. Help securing your firearms, large quantities of medication, or other lethal means if suicide is a risk. Ask, ask, ask. A simple way to ask is, I'm trying to get mental health care. Could you help me with the copays or the first few appointments? Or help me make the calls to find a sliding scale provider. If they can't provide money, they might be able to help you with childcare or meals or appointment reminders or sitting with someone during a crisis. And remember, if you can't afford your mental health copays for your therapists or your prescriptions, call 211 Connect and see if there's help with something else you might need, such as a food resource. There might be food pantries near you that you can go to and get food every month and then be able to afford your copays. Or there might be help with your gas bill or your electric bill or home repairs. Or help with getting insulation for the house that you own, so your heating costs are lower, so you can afford your copays. Before choosing any plan or provider, verify the exact therapist, psychiatrist, clinic, and hospital in network and accepting new patient. Ask for visit cost, therapy, copays, deductibles, and cancellation policy and medication coverage. Ask whether the clinic offers financial assistance, payment plans, or reduced rate slots. Keep a written record of calls, names, dates, insurance reference numbers, and promised follow-ups. If denied coverage, request the denial in writing and ask how to appeal or obtain an exception. That must be regarding your plan or your provider. And I already said, get a notebook. Put some tabs, get a thick notebook, binder notebook, and put tabs on it. Signs and symptoms, this one grouping. Your research with finding providers or therapists is another grouping. A medication list is another grouping. Get a binder, take it with you to each appointment, keep it with you. Now, I can tell you this, that when the pandemic hit, and I was fully aware and experienced in education and mental health signs and symptoms. I did education and outreach for several years on mental health. People that never experienced any signs or symptoms did during the pandemic. So it can happen at any time. And it could be a medical condition, as we discussed. Um, all my references will be in the summary of this video. I hope this video helps others. Please share it, like, hit subscribe. Like I said, I do follow true crime, high profile cases, and I do cover them in a different way. This certainly was a different way. But I hope it helps anybody that watches this. If there's one resource that you didn't know about, it's done well. Thank you for watching, and have a great day or evening. Bye.